our next presenter is Erika Yasuhara, and the chair for this session is Elisa Yasuhara. Oh yeah, Elisa. So yeah, now introduce Erika Yasuhara, and then let's proceed.
Okay, thank you. Erica Yasuhara is a college student who is currently attending Wellesley College in Massachusetts. She's passionate about biology, medicine, and health equity, and she aims to raise awareness about the health inequities worldwide. She has done extensive research through MIT to support her study. In the future, she aims to become a medical professional who continues to support and stand for equality in public health care. Leading to read health inequities, an undergraduate approach to public health data. Undergraduate students are increasingly engaging with public health questions related to health inequities and social determinants of health. Open access datasets make population-level data widely available to learners early in their academic training. However, relatively little attention has been devoted to how students learn to responsibly and effectively interpret these complex datasets. Heart disease is the #1 cause of death in the United States, with hypertension acting as one of the many risk factors. Lower status of various SDOH have been linked with higher prevalence in hypertension. Through this educational lens, we can reflect, educate, and interpret these data sets. In New York City, the study identified a strong connection between educational attainment and hypertension. In Brownsville and Ocean Hill, only about 21% of adults held a bachelor's degree, and hypertension prevalence reached 36%. In contrast, in the Upper East Side, where over 80% of adults had college degrees, hypertension rates were roughly half that. These disparities were also linked with higher poverty, lower employment, and greater housing insecurity with lower education areas. The study highlighted the Harlem Health Advocacy Partners program as an effective intervention, showing how community health workers can improve blood pressure management while addressing broader social and environmental barriers. This prior work provides an important foundation for our ongoing research. While established in education as a key determinant, our current project expands this framework by exploring additional factors such as food insecurity, poverty, and built environmental features like walkability and food access. By building on these findings, we aim to determine correlations between the variables and, if given time, identify targeted evidence-based interventions that can reduce hypertension disparities throughout New York City. Using Boston as a baseline benchmark, each member covered a different city that demonstrated a disparity in hypertension. Diet has been long been tied with cardiovascular diseases and hypertension. The environmental and socioeconomic context one experiences ultimately affects one's diet choices. Limited access to healthy food, both in cost and availability, affect hypertension. Jalen's goal this semester was to fill in the gap of food insecurity indicators to correlate with hypertension. And these are the different ways that framing matters. For example, this deficit framing as well as context framing. In transitioning my project to New York City, I mapped CDC Place's 2021 estimates of crude prevalence of hypertension by census tract. This was helpful to gain a sense of general geographic patterns of hypertension if disparities existed when sorted at neighborhood by neighborhood level. Based on this semester's literature review, Erica decided to go with the Retail Food Environmental Index, modeled by Glover and others at the University of Florida. This study models food insecurity by scoring census tracts by availability of health food retailers. This score is determined by the percentage of healthy retailers out of the total food retailers. Each census tract has a catchment area determined by transportation availability, and any retailer within this area is accounted for in the index. They chose this methodology because of the granularity that was achieved in the study, and though it effectively takes account that people shop and travel outside of their census tract while illustrating food availability by accounting that was unhealthy and healthy. Ultimately, in attempting to replicate this data over the last few weeks, they met a lot of roadblocks. The transportation data in the study for multi-origin index one that accounted for food access based on home and work location was no longer available. In response, they've moved their project to a single origin index, which only accounts for access from home. Additionally, they did not have access to the same retailer data. Thus, they shifted the methodology and spent a lot of time cleaning the retailer data as shown in the next slide. This semester, they were able to start the process of cleaning food retailer data. Using ArcGIS Pro and Python, they were able to start cleaning and categorizing the retail stores by census tracts. To map food retailers they used, in New York City Department of Agriculture's retail food stores, this data included georeference and establishment type of every food retailer in New York City. They are then able to join this data into the tiger/line shape files to organize them by census tract. Next, they were working on organizing retailers as healthy and less healthy. This was done based on a mixture of literature review and previous CDC statements. Through literature review, they were able to find sets of keywords to sort these retailers. Here's the current map on Queens, Upper Manhattan, and Bronx. And I don't have the graph right now, but this is the end of Erica's presentation. Thank you.
Thank you so much for presenting her work, Elisa. Yeah. So